Hi, my name is Carly. I'm a critical care nurse in Dartmouth Surgical ICU. My capstone was focused on peripheral intravenous infiltrates and extravasations, also known as PIVIEs, with a specific focus on reducing the PIVIE rates in my surgical ICU. With efforts to reduce hospital-acquired conditions, the use of central lines have decreased, which has proven beneficial to our patients, but also stretched the limitations of our peripheral IVs, quite literally. The purpose of my study was to gain knowledge of my unit's current comfort level by introducing an anonymous survey, as well as a thorough literature review highlighting current evidence-based practice guidelines to overall reduce the amount of PIVIs seen in the intensive care population. We'll start by differentiating the difference between an infiltrate and extravasation. An infiltrate is when a non-vesicant, also known as an irritant, IV solution or medication leaks into the surrounding tissues during an IV administration. An irritant can cause inflammation, but not necrosis, meaning tissue death. This is one of the leading causes of all complications of peripheral IVs. In contrast, an extravasation is the accidental leaking of a vesicant solution or medication into the surrounding tissues, potentially causing ulceration and tissue death. As you can imagine, this can lead to many complications for our patients. Some of the major ones being possibly needing debridement of the tissue because of the damage done, the swelling of a limb so bad that it cuts off the circulation, which is called compartment syndrome, increased cost to facility, longer inpatient stays, and more invasive procedures to our patients that can include an insertion of another line, potentially a more invasive line, such as a central access, and overall pain and discomfort. The ICU in general, I think, is a higher vulnerable population when it comes to PIVIE risks. They're often used in life-saving medications such as vasopressors, which is a highly vesicant drug. Due to a critical state of our patients, we're administering large volume resuscitation, which means a lot of fluid going into veins at high rates. Usually makes patients more edematous, usually resulting in catheter movement, leading to a PIVIE. Almost all of our patients have altered mental status, making the ability to communicate pain very difficult, if not impossible. A study by Paramore showed that 76% of patients who experienced compartment syndrome had an altered ability to communicate. When it comes to the nurse's responsibility, we look at the TLC method of assessment. TLC stands for touch, look, and compare. So when we go into a patient's room who has infusing medications through peripheral IV, we're always assessing if the site is warm or cool. We're looking to see if the skin color is varying in colors such as red or streaked. We also compare the limb to the other arm that's infusing to make sure that there's no additional swelling around the site. One of the biggest nursing responsibilities is choosing the appropriate vein to insert the peripheral IV. When it comes to the longevity of the peripheral IV, the choice of vein and the catheter size is really important. The forearm has been proven to be the most optimal vein to use. This is a place where the arm does not move and the catheter has less chance of getting fractured, therefore leaking into the surrounding tissues. The size of the catheter is important. Using the smallest catheter possible that will accommodate your therapy will lessen your risk of a PIVIE. The nurse's responsibility is also being an advocate for the appropriate access. Sometimes these patients need a bigger line and central access, which is not always optimal, but when it comes to the safety of the patient, then a central line might be needed. The survey that was introduced on my unit was not to gain necessarily knowledge of what the nurses know already about peripheral IVs. It was more or less to assess their current comfort level with insertion, monitoring, and troubleshooting. The results I got from the survey were actually quite surprising. When it came to the nurses' confidence about placing peripheral IVs, 40% of nurses felt like they were comfortable didn't feel like they were comfortable with placing or inserting peripheral IVs independently. A well-functioning IV starts from the point of insertion, so it's very important that nurses are feeling competent and comfortable about placing IVs on the spot and quickly when it comes to administering life-saving medications. Another question asked was if nurses felt comfortable with the amount of education they received during their orientation. This was one of the biggest questions that I felt was the most important because 45% of our nurses felt they didn't get enough education or practice before it was their responsibility ultimately to place them at the bedside. The last question I'll discuss from the survey was if preventing a PIVIE was 100% preventable. We are told that they are preventable situations, but I think in the ICU, the results of the survey can actually show that 80% of our nurses felt like they cannot be prevented. It really shows how vulnerable the ICU patients are and the situations that they get into, and it comes really down to life or death situations. And the focus on some of those barriers that prevent PIVIEs from occurring was the highlight that came out of the nursing survey. Some of the barriers that came to mind and some of the barriers that nurses spoke out about were the time constraints of the nurse. It is evidence-based practice to assess our IVs every hour when they're infusing. This can be difficult when you have an unstable patient next door, and you don't always have the ability to come check into your patient's room in that timely manner. The emergent use of life-saving medications such as those pressors we talked about before in a peripheral IV, because hasn't been time to place another line when it comes to sustaining a safe blood pressure or preventing a PIVIE. The blood pressure will always win, and that's one of the largest barriers that nurses are feeling that can prevent a PIVIE from occurring. And the placement of IVs that are already in place, they often getting patients from the emergency room and EMS, and the most easiest and one of the biggest veins in the arms is to access are the ACs and the elbow. This is good for a temporary solution, but in all reality, when it comes to long ICU care, we should be taking these IVs out and placing them in the forearm, which are the more optimal vein to use. So where do we go from here? With all this newly learned information, I've begun work on an online educational tool the nurses can use and access easily at the bedside. The tool will have a step-by-step process of inserting the right way to insert an IV so that everyone is doing it the right way every time. A friendly reminder to use the smallest catheter when possible in the biggest vein as possible, and the TLC method and common signs and symptoms of a PIVIE, and also a really helpful vein map of the different veins in the arm that's a good visual representation of which optimal veins we should be using. One of the biggest outcomes that could potentially come out of this capstone project is the possibility of altering the orientation process to include shadow time with vascular access that allows new nurses to get hands-on experience of inserting IVs with guidance of a professional and get really the adequate amount of practice before it's their responsibility at the bedside to be placing them in these life-threatening situations. So that's exciting work to be done. So I'm hoping that after providing education in a staff meeting, as well as creating this online tool for the nurses and the continuous diligent work of the nurses at the bedside monitoring their IVs, we hope to overall reduce the amount of peripheral IV infiltrations and extravasations on the ICU floor.